To start?
You can start now.
Okay. Good morning, everyone. Great pleasure to be here. Thanks, Sandeep, to give me this opportunity to be with these guys on stage. We will have a very interesting debate on ICP monitoring in children. From Brazil, we have Artur da Cunha, pediatric neurosurgeon from Recife and past president of the Brazilian Society of Pediatric Neurosurgery. And also Anthony Figaji from South Africa, pediatric neurosurgeon and secretary of the ISPN. ICP monitoring is a controversial issue. We'll try to end with some statements if we can, and try to see the benefits, the risk, and when we indicate and why in children. Thank you very much to be with us, Artur and Tony, and sure, we'll have an excellent debate. Welcome.
Thank you.
Thank you. Beautiful view, Tony.
Thank you, you too.
From Cape Town. Yes, this is Cape Town.
That's Cape Town, yeah.
Okay. Wonderful.
Fantastic.
Yeah, and Ria is Recife, the center.
Very
of
nice,
Recife.
very nice. I love that city.
Okay.
So you're going to start, Archer?
No, I think you start or I start.
Well, would you mind starting? There are a couple of things I still need to do on mine.
That's okay. Then I can start. No problem.
Great.
Yes.
Fantastic. Thank you.
Let me organize my thing here. So
take your time. You can share your screen. We are here. Don't worry.
Oh, compartilhar tela.
Yes. Sharing screen. Yes. And
share screen.
We are already seeing your screen now.
Did you see my screen?
Yes, it's the logo ISPN in blue.
Okay, wonderful. Okay.
Welcome.
Good.
Thank you.
So, thank you very much, Sandeep and Nelci, for including me in this educational program. I think this webinar program offered the opportunity to exchange ideas and, of course, see, even in a cyber way, our good friends. One of the great challenges of pediatric neurosurgery, also the anesthesist, the intensivist, is to diagnose, monitoring, and treat intracranial hypertension in pediatric patients, either in acute and critical forms or in chronic forms. Widely differing conditions, including congenital lesions, vascular disease, neoplasm, metabolic disorders, infectious and inflammatory disease, and trauma, require evaluation and treatment for elevated intracranial pressure. I have to say that the focus is not to be against or for the monitoring of the ICP. The focus is on searching for evidence that support management guides in pediatric TBI patients. Without forgetting the situation that presents low and chronic elevation of intracranial pressure, our main attention will be the monitoring of ICP in critical elevation, especially in traumatic brain injury. The outcome of patients with traumatic brain injury is related to many factors, and one of the more important is the intracranial pressure. A rapid and refractory increase in intracranial pressure is a major cause of death in brain injuries, while prolonged intracranial hypertension, in addition to mortality, it is also associated with severe and irreparable neurological sequelae. The human skull is a closed box with a constant volume in adults, but it varies according to the growth stage in children. The cranial content is formed by brain tissue in 90%, cerebrospinal fluid in 10%, and blood in 10%. Considering that the total volume is constant, the increase of one of the components means the decrease of the others. However, this compensatory mechanism is not unlimited, and its exhaustion determines intracranial hypertension. Concerning the cerebral parenchyma, slowly growing mass causes compression and deformation, while rapid development process can result in hernias and ischemia. The ability of the brain to adapt itself to masses also depends upon the viscoelastic properties of the brain that may be altered in the case of cerebral edema. In case of raised ICP, 30 to 70% of compensatory reserve for volume exchange or buffering occur through the mechanism of increased absorption or displacement of CSF into the spinal subarachnoid space. The compensatory mechanism concerning blood volume are very limited in acute raised ICP. The blood volume adaptation mechanism could be evidenced by scalp vein supply via the emissary system that characteristically become engorged in children with intracranial hypertension. This must represent a mechanism to dissipate ICP. In many centers, protocols for patients with severe brain lesions are based on adult protocols, which can lead to management errors. We know that children can tolerate an intracranial mass effect for some time without evident signs of intracranial hypertension. Infants with open suture accommodated added intracranial volume by skull expansion, often without raise or with little elevation in ICP. However, extrapolated the ability to compensate for the increase in volume, a rapid and dramatic deterioration is installed, and this could lead to a reversible and incurable state. Often, in children, intracranial hypertension can be accompanied by subtle change, such as irritability, anorexia, bulging fontanelle, and abnormal increase in cephalic perimeter, which we do not see in adults. There is documentation of initiative to monitor intracranial pressure attributed to Guillaume and Jani in an article published in 1950. The author studied variations in intracranial pressure through a direct ventricular puncture. However, the Lundberg studies, published in 1960, also definitively established that symptoms of abnormal brainstem function resulted from abnormal intracranial pressure, and even variation in ICP could produce clinical symptoms. He described three basic shapes of ICP: A waves, plateau wave, B waves, and C wave. The most innovative results of continuous monitoring was the discovery of plateau-shaped waves that produce paradoxical symptoms previously designated as decerebrate. In summary, A wave is characterized by the elevation of the ICP, which after being maintained for a few minutes reduces to a slightly higher base than initially registered. A wave signals the compensatory exhaustion of the craniospinal volume. B wave reflects a short and modest rise in breathing-related ICP, and C wave is related to arterial pulsatility, possibly reflecting decreased compliance. Several ICP monitoring models have been developed from Lundberg studies in order to guide measures to maintain the ICP at normal levels within an adequate cerebral perfusion pressure, good oxygenation, and avoid brain herniation. The most traditional methods are invasive. In our experience, and also reported by many authors, the models for monitoring by ventricular catheter implantation are very useful for measuring the intracranial pressure and allowing the removal of CSF that allows a quick response with decreased pressure. Unfortunately, with very small or collapsed ventricle, due to cerebral edema, a ventricular puncture is very difficult. Infection, intracranial hemorrhage, and obstruction of drainage are a common complication in ventricular drainage. The market today has a variety of manufacturers and models with epidural, subdural, interparenchymal, and intraventricular sensors without CSF drainage. Some models use sensor coupled to optical fibers, and some systems allow continuous recording of intracranial pressure. In general, monitoring by implanting sensors in the epidural space is not very efficient, in addition to the risk of causing epidural hematomas. The risk of infection in this system is lower, but reading errors are frequent, regardless of the model or brand. The cost of these monitors is very variable, and some can be very expensive, making it impossible to use in many countries. Great care is recommended for patients with coagulopathy due to the increased risk of bleeding during the device implantation procedure. Technology has been developed in order to allow safer monitoring. So this system developed by RawMedic, where after the implantation of a sensor, the ICP can be monitored telemetrically. The advantage of this system is the lower risk of infection and the ease of handling the patient. For example, it facilitates change in the patient decubitus and displacement for exams outside the ICU, but is also very expensive. New technology and approach have been developed looking for non-invasive ways of monitoring ICP. These technologies have proved to be very useful in the diagnosis and monitoring of chronic hypertensive process, but still needing experience with critical patients who need quick and accurate response. An example is the system developed by Brain Care Health Technology, which has already been used in several departments in Brazil. Through a tape around the head, without the need for cuts or perforation, with the patient comfortably awake and collaborating, it is possible to measure and monitor the ICP. The procedure is very simple, and even small children tolerate it very well. Please, I'm not doing any advertising, although I seem to be doing it. We are very excited about this system that we will soon be implementing in our department. Another advantage of this system is that it is connected to a cloud platform, allowing easy access to information from anywhere that has access to the internet. Still, as an example of non-invasive monitoring of intracranial hypertension, this interesting article was published in Child Nervous System last month about the use of optic nerve ultrasonography in the diagnosis and monitoring of pediatric idiopathic intracranial hypertension. We know that the NMR has made major contribution to the changes seen in the optic nerve in intracranial hypertension. The advantage of the ultrasound is the possibility to repeat examination without sedation. So, however, now let us return to our discussion. Is intracranial pressure monitoring really important? Several studies have shown that in severe brain trauma in pediatric patients, 32% have ICP greater than 20 millimeter mercury, and 80% we observe signs of cerebral edema in CT scans. High ICP is related with poor neurological outcome and direct cause of death in 10% of cases. With that, we concluded that intracranial hypertension is an important prognostic factor and that it needs to be diagnosed and monitored concerning the response to treatment. Of course, monitoring intracranial pressure can provide valuable information regarding the evolution of treatment. However, it is a serious mistake not to observe all the important clinical, laboratory, and imaging aspects. Tomographic control is important and allows the diagnosis of the growth of a brain contusion or intracranial hematoma that did not exist previously. In many pediatric trauma emergency and pediatric intensive care units, computed tomography findings are more valued and the reason for not implanting ICP monitoring device. Some articles only consider the use of external ventricular drainage with the need to remove CSF. Reducing intracranial pressure can also have disastrous consequences, which is why we insist that ICP monitoring is an important tool, but it is only one of the tools in the management of patients with serious brain injuries. Conscious children with a diagnosis of mild or moderate trauma do not indicate ICP monitoring. They can be followed up with clinical and imaging monitoring. The focus on the management of intracranial pressure in brain injuries must take into account a very important factor, which is the adequate maintenance of cerebral perfusion pressure. Adequate CPP requires adequate systemic blood pressure as well. That is, cerebral perfusion is more negatively sensitive to arterial hypotension than to intracranial hypertension. It is not yet known exactly the minimum tolerable CPP values in children, nor it is known exactly how long they support a low CPP. However, despite some controversies, most studies recommend a CPP between 45 and 60 millimeter mercury, depending on age. Therapy to lower raised ICP often does so at the expense of reduced mean arterial pressure, and as a consequence, CPP may not improve or even decrease it. In conclusion, the ICP monitoring in severe brain injury is very important, but as part of all the intensive care. In other words, monitoring the ICP requires a well-equipped ICU and a well-trained team. The wrong interpretation of ICP value could influence wrong therapeutic decisions, and that is very dangerous. All monitoring instrument reports should be analyzed together and conflicting data should be reviewed. So, when should we introduce intracranial pressure monitoring? In most guidelines and papers about the topic, a Glasgow Coma Scale 8 or less is indicative of ICP monitoring. But we know that the clinical presentation can be changed very quickly and perhaps improving. For example, some children arrive at the emergency room with Glasgow Coma Scale 8 or less, sometimes using analgesics and sedatives. Tomography showing no expansive lesions and the cistern are open. Perhaps we can stabilize our patient and review the Glasgow Coma Scale later on. The presence of hypoxemia and hypotension reduce the Glasgow Coma Scale score. Primary management to correct this situation is important to assign the best Glasgow Coma Scale. On the other hand, a CCT, a tomography scan with lesions with a mass effect and signs of intracranial hypertension is an indication of the need for monitoring of intracranial pressure, but it can also be an indication of immediate surgical approach without prior monitoring. Although the presence of open fontanelles and suturing in severe TBI in infant does not exclude the possibility of developing intracranial hypertension, very few cases have required ICP monitoring. We can see and feel with the fingers the presence or absence of intracranial hypertension, as well as clinically observe the patient's response to therapeutic measures. As previously mentioned, ICP monitoring requires a very good ICU with a good team. ICP monitoring, because the inability to perform periodic clinical control doesn't help to match the patient. Only in exceptional situations, the ICP monitoring device should be implanted because clinical control is not possible. The decision to start monitoring intracranial pressure must be careful. Once the monitoring of the ICP starts, the treatment of hypertension must be started simultaneously. After installing intracranial pressure monitoring, if there is an increase in pressure, please check all these situations that you see here, because this situation can relate with high ICP. So it is unclear among TBI patients who are at real risk for intracranial hypertension, especially among children and infants, and there is no evidence regarding the ICP values for starting treatment. Consequently, there is still uncertainty as to which patient should have ICP monitored and the treatment of intracranial hypertension. Some studies have found that more than 80% of children with Glasgow Coma scale lower than 8 had ICP greater than 20 millimeter mercury. For this reason, some authors argue that this patient with or without abnormal tomography should be monitored for ICP. The argument is that there can be rapid deterioration, herniation, and death of the patient. However, there is consensus that low Glasgow Coma scale, normal or abnormal CCT picture, presence of abnormal movements, the cerebrate or the corticate, arterial hypotension, and ICP greater than 20 millimeter mercury are indicative of immediately start of treatment. Treatment can range from clinical and medical management, such as decubitus elevation, intubation, sedation, hyperventilation, hyperosmolar solution, to surgical management, such as decompressive craniectomy. Regarding the decompression craniectomy, there are several controversies about the timing. I advocate early decompression craniectomy in extremely severe cases. Glasgow Coma scale lower than 8, CCT showing diffuse cerebral edema with ventricular collapse or localized edema or expansive injury with significant midline deviation. In this case, ICP monitoring must be installed at the same time as the decompression surgery. Of course, ICP monitoring helps in assessing the response to treatment, making it possible to evaluate the procedure performed and avoid unnecessary conduct. However, as already mentioned, it is one of the aspects to be evaluated in the absence of pediatric guides based on strong evidence. Patients should be analyzed on a case-by-case basis. How long should intracranial pressure monitoring and treatment last is a difficult question to answer, depending on the causes of intracranial hypertension and the response to treatment. More or less long monitoring may be necessary. Normal ICP values are not indicative of suspension of monitoring or intensive care. Patients suffering from severe TBI, for example, may need longer monitoring, even with ICP tending to normalize, due to the risk of secondary hypertension, a rebound effect after reducing therapeutic procedure. ICP monitoring alone does not safely inform when to stop treatment. In fact, one of the reasons alleged in some studies that do not recommend ICP monitoring as routine procedure is that they observed that monitored patients tend to have a long stay in ICU than those not monitored. Wow. Despite so much data recommending that ICP monitoring is indispensable for the diagnosis and monitoring of intracranial hypertension, there are still many controversies. At the conclusion of this article, published in 2012, for patients with severe traumatic brain injury, care focuses on maintaining monitored intracranial pressure at 20 millimeter mercury or less was not shown to be superior to care based on imaging and clinical examination. What about the article published in 2014? Despite current Brain Trauma Foundation guidelines, ICP monitoring is used infrequently in pediatric population. The data suggests that there is a small yet statistically significant survival advantage. But all patients with ICP monitor experienced longer hospital length of stay, longer intensive care unit stay, and more ventilator days compared with those without ICP monitor. Of course, with so many complications associated with this procedure. This article, published in 2015, concludes that ICP monitoring contributed very, very little to mortality rates. And what do you think of the argument for not monitoring the ICP as a conclusion of this article? Our study confirms that many children with severe TBI do not undergo ICP monitoring, mainly due to rapid improvement or moribund status. A subgroup of patients with reassuring cerebral CT scan was not monitored. Further research is necessary to assess if imaging should be considered in an ICP indication. This article, published by India author in January last year, presented a retrospective study involving 61 children with severe traumatic brain injury. 23 underwent ICP monitoring and 38 were not monitored for ICP. Despite ICP monitoring can be safely carried out in children with severe TBI, did not reduce the incidence of death, cranial surgeries, duration of mechanical ventilation, hospital stay, or improved the outcome at discharge when compared to children who were managed without ICP monitoring. The Glasgow Coma scale and the age at admission were main predictors of outcome at discharge. So, perhaps we may have to think about it again. To conclusion, the effect of a rapid and prolonged increase in ICP in infants and young children, considering an immature brain with its high water content and changing myelin content, is extremely damaged. Glasgow Coma scale adapted to pediatric patients and infants, and a careful neurological examination remain the most used procedure in infants and young children with TBI. The monitoring of ICP is an excellent tool for diagnosis and treatment of intracranial pressure, but the values must be interpreted taking into account the patient's age, underlying disease, clinical condition, and especially the image exams. ICP monitoring is not indicated in case of minor or moderate head injury, especially if the child is awake. ICP monitoring is an invasive procedure and requires complex ICU care. ICP monitoring can present many complications such as obstruction of the drainage catheter, incorrect reading of intracranial pressure, intracranial hematoma, and serious infections such as meningitis and meningoencephalitis. Finally, further studies are needed to define guidelines for monitoring ICP in pediatric patients, and it is necessary to develop a precise non-invasive method for ICP monitoring in critical care. This topic is really very controversial, with perhaps more questions than answered. Let's continue research. Thank you very much.
Thank you very much, Artur. I think it was really put on stage. It's necessary to do ICP monitoring in children. It's necessary. What's the indication? We will see with Tony if he give us more answers than questions, Tony. It's for you now, Tony. Welcome. Thank you.
Great, thank you very much. Can you all hear me? Can you see my screen?
Yes, Tony, we can see you and you are sharing your screen with us. Thank you.
Marvelous, marvelous. So, I was asked to speak in favor of the motion that ICP monitoring is useful in pediatric TBI. For my disclosures, I have no industry relationships whatsoever. And I thought Artur was going to argue quite strongly against the idea of ICP monitoring. So I had all these things that I was planning to say, terrible things about Artur and how wrong he was, which I felt bad about because Artur is such a nice guy. He's one of the nicest guys in neurosurgery. But he had a very balanced view. So fortunately, I don't have to say any of those things. And I can just make my argument. And what I want to do before I get to some of the literature, some of which Artur has already touched on, I want to talk about a couple of general aspects of why it is difficult to do good quality studies, and one of the reasons why there aren't good quality studies in ICP monitoring for TBI in general or neurosurgery in general. And then the second component, I want to look at a few specific things about ICP monitoring and why it's so difficult to kind of nail down the benefit and why there's this disconnect from what experts do and from that which is published. So principles, general principles. The first one is surgical conditions are just really, really difficult to study. They're not like internal medicine. And internal medicine, the vast majority of randomized controlled trials are done there. So that's much more, that's much easier. Very often it comes down to a dichotomous question, very often on a medication. And almost literally, is it a red pill or a blue pill? And internal medicine lends itself to that. And that's relatively easy because there's very little variance. There's some variance still because patients, their pathophysiology may be a little bit different. They may have a different genetic susceptibility to the medication. They may have comorbidities. But the person giving them the medication and how they're given the medication has got nothing to do with the outcome. Where surgery is completely difficult. It is completely different and much more difficult because you not only have that variance, you also have the variance that's brought by the surgeon and the way the patient's treated. So the way that the patient is worked up for surgery, the preoperative workup, the quality of that, the quality of the imaging, the interpretation of the imaging, the skill of the surgeon, how much experience he or she has with that particular condition, what tools the surgeon has at his or her disposal, from the microscope to the CUSA to intraoperative electrophysiology to intraoperative imaging, to the quality of the ICU care post-op, to the quality of the rehab. There are just so many more conditions in surgery that have to be taken into account when you do a randomized controlled trial. That's why it's particularly difficult to do in surgery. And then it's much more complicated than that because the brain is much more complicated than the other organs in our body. So with all due respect to my pulmonology and cardiology colleagues, the lungs are bellows and the heart is a pump, and that's pretty much what you have, whereas the brain's complexity is much, much greater. So you have surgical conditions which are already much more difficult to study and much more complex because of the management factors. And then on top of it, you have neurosurgery, which is the most complicated organ in the body. So it's not surprising that, from my point of view, that neurosurgical conditions are the most difficult conditions to study and the most difficult conditions to apply a randomized controlled trial to. Or you can do a randomized controlled trial, but you may well not get it right. And then so for instance, these are patients of mine fairly recently. You all recognize them as brainstem lesions. Now, we know that we're never going to do a randomized controlled trial of how to take out brainstem lesions or the value of a radical resection of brainstem lesions. And most people would understand that, because the complexity of the factors that you have to take into consideration, the type of the lesion, exactly where the lesion is, the morbidity that the patient already has, the skill of the surgeon, the intraoperative neurophysiology, all really, really difficult. And we can't even agree, for instance, on whether intraoperative neurophysiology is a good thing to do or not. Those people who are good at this will say absolutely, but if you look at the literature, it's not necessarily strongly supportive of it. So that's the one principle. It's complicated. Two, the second principle is it's not about the bike. And so this is the title of Lance Armstrong's autobiography. Lance Armstrong, the now disgraced cyclist. And they titled this book, and they titled the ad campaign from Nike, it's not about the bike, to emphasize that it doesn't matter really what bike he's riding. It's about the person riding the bike and how he's riding the bike, how much experience he has. Now, subsequently to that, we've also known that it's about the quality of the stuff that he was injecting. But in general, the point is well made, that it's not just about the instrument. So you can give Roger Federer an old tennis racket from 50 years ago, and you can give me one of the best technically equipped rackets, and I'm still not going to get a point off him, because it's not about the equipment, or at least not just about the equipment. And we can extrapolate that thinking to the monitoring that we do as well. A monitor is never going to make a patient better. It's not going to make a patient worse. Whether the patient improves or not, and the only thing that we can evaluate is what we do about that monitoring. And when we do studies like the randomized controlled trial of Randy Chestnut that we'll get to in a moment, you have to evaluate it in terms of what they did about the monitoring, not the monitor. It's not a trial of a monitor. It's a trial of a strategy in a particular circumstance. All right, so those are the general principles. So there are a couple of specific principles about ICP monitoring. This is the first one. If you don't measure it, you don't know. If you don't measure intracranial pressure, you don't know what it is, and you don't know what you're treating. So it's pretty much the same as treating blood pressure without knowing what the blood pressure is. You can over-treat it, you can under-treat it, you may be treating a hypertensive condition that's not even there. Makes no sense that you don't know it. And if you think you know it, you can say, well, I can look at the scan, and the scan tells me whether the intracranial pressure is elevated or not. That's not true. We think as neurosurgeons we can do that, but when we actually look to see whether we can or not, and this is a study that we did several years ago, took experienced neurosurgeons and looked at scans and tried to predict whether the intracranial pressure was elevated or not. Their specificity and sensitivity at getting that right wasn't very impressive at all. So we think we can do it, but we can't. And then there are non-invasive measures as well. And all the non-invasive measures, in my experience, have major limitations. So they may have a role, but in acute trauma, where there's an acute raise in pressure, they are not very good, because their sensitivity and specificity just isn't good enough in the acute setting. And then even if it was good enough, the problem with intracranial pressure, especially in children, because children are much more dynamic than you see in adults, because a lot of their intracranial pressure changes are vascular in nature. So you'll have a child like this, very, very stable, and then a few minutes later or several hours like this. And a non-invasive measure that's done once a day or even twice a day really doesn't give you this kind of information about what happens to intracranial pressure minute to minute. Okay, so that's the first one. The second one is that there are several different causes of increased intracranial pressure. We think of it as one homogeneous concept, but there are several different causes. So some of those are easy. Hematoma, hydrocephalus, contusions, you can see on a CT scan. Brain edema, interstitial edema, cellular edema now becomes a little bit more complicated because the imaging of it is not as easy. Hyperemia, much more difficult to diagnose. CO2 changes in cerebral blood volume, much more difficult. Impaired autoregulation, where it's you pushing up the blood pressure that's pushing up the intracranial pressure, gets a little bit more difficult. Subclinical seizures, spreading depolarizations. So all these things can cause an increase in intracranial pressure. But if we treat them as if they're all the same condition, there's no mystery why patients don't get better. So if a patient has subclinical seizures, you don't do a decompressive craniectomy to treat the ensuing raised intracranial pressure. You treat the seizures. So that's one of the problems that I've always had with the stepwise approach that we have to treating intracranial pressure. Doesn't really make much sense, right? Because you're not focusing on the cause of the intracranial pressure. You're just treating intracranial pressure as if it's a homogeneous concept, which it never is. So this is an example of why you have that heterogeneity. It's brain oxygenation on the y-axis and intracranial pressure on the x-axis. Now, if it was one homogeneous condition, raised intracranial pressure, then you'd expect a relatively linear and predictive negative correlation between intracranial pressure and brain oxygenation. But when you actually plot the data points, the paired data points of intracranial pressure and brain oxygenation, you get a cloud where the slope, the regression line, is slightly positive. Why? Because there are just so many different things that cause raised intracranial pressure, and how intracranial pressure affects pathophysiology in the brain, the cerebral blood flow and cerebral blood volume varies between patients because the pathology differs. Number 3, ICP thresholds are not the same in everyone, in part because there are lots of different causes of raised intracranial pressure. So you can have a condition like this, intracranial pressure goes up, brain oxygenation and cerebral blood flow goes down, as you'd expect. But here you can see the takeoff of the intracranial pressure was at 15, not at 20. And you can also have this, where intracranial pressure goes up, but brain oxygenation goes up as well, even though it's going above 20. So the underlying cause of the intracranial pressure is critical to try to understand, and its effect on the rest of the physiology of the brain, because you're just thinking about intracranial pressure. And of course, brain pathophysiology, because the brain is so more complex than any other organ, brain pathophysiology is much more complicated than just the idea of the pressure inside it. Here's another example of intracranial pressure going up because CO2 goes up, and look where that relationship changed. Brain oxygenation goes up initially because you're getting cerebral vasodilation, but then there's a critical threshold at which the relationship changes because the cerebral blood volume is now having a great effect on oxygen diffusion through the tissues. And that in this patient happened under 15. And then to make it much more difficult, the vast majority of what's been written about TBI is in adult patients. Children are much more difficult than adults because they are physiologically different to adults, but also they're physiologically different to themselves. So a 2-year-old is different to an 8-year-old, is different to a 12-year-old. Important fact number 4, the physiological responses to standard interventions that we do all the time differs between patients, even though we often expect that they're exactly the same. So yeah, I'll show you 2 examples of dropping the blood pressure, 2 examples of raising the blood pressure. So look, just for now, look at the relationship between mean arterial pressure and intracranial pressure. Drop the blood pressure, the intracranial pressure goes up. Drop the blood pressure, but the intracranial pressure, at least the intracranial pressure goes down. Drop the blood pressure, the intracranial pressure goes up. The same maneuver, 2 polar opposite effects. Here we raise the blood pressure and the intracranial pressure comes down as a consequence. Here you raise the blood pressure and the intracranial pressure goes up as a consequence. So the same maneuver, 2 polar different outcomes with respect to intracranial pressure. Why? because if patients have intact autoregulation versus impaired autoregulation, what happens to intracranial pressure when you raise the blood pressure is completely different. Similar with CO2, so just look now at what happens with intracranial pressure and brain oxygenation. Here, you're dropping the CO2, the brain oxygenation comes down because you're vasoconstricting. Here, you're dropping the CO2, but the brain oxygenation goes up. Again, physiologically completely different, even though you may expect that the patients are going to behave in the same way. Fact number 5, there are things that are going on in the brain that we don't know about because we don't look. We're just looking at the intracranial pressure, or in some situations, we're not even looking at the intracranial pressure. We're just looking at the scan. So this was a study we did several years ago that looked at patients who were well managed by the guidelines that were published at the time. So the intracranial pressure was fine, their blood pressure was fine, they had decent systemic oxygenation, decent transfusion, and still a third of the patients had brain oxygenation less than 10 millimeters of mercury. So it's not just low, it's below a critical threshold. So we looked at them, we thought they were being managed completely fine, and still a third of them had critically low brain oxygenation. So there were things going on that we weren't seeing. One of those may be subclinical seizures. Again, they're subclinical, so by definition, you can't see them. And if you don't look for them, you just don't see them. Often, if you've got a monitor in place, you get these regular changes that you can then correlate with continuous EEG if you've got that in place. Okay, so those are the principles. The broad principles about the difficulty of doing these kinds of studies in neurosurgery, and then some specific ideas of why it can be difficult to look at ICP monitoring, specifically in TBI. Now, let's look at some of the categories of the literature, some of which Artur has already mentioned. For me, they fall into 3 categories. 1, articles supporting intracranial pressure monitoring. 1, retrospective, second one, the retrospective articles where ICP versus non-ICP patients are compared, and then the 1 randomized control trial that we've got. Okay, so let's look at this. Articles supporting intracranial pressure monitoring. So invariably, these have been the ones that have reported the best outcomes. So there are several of them. That was our experience as well. Our mortality in our ICU for severe traumatic brain injury in children historically was 40–50%. So that was particularly high. We started an organized neurocritical care program, didn't change ventilation settings, all those kinds of general critical care at all. And now mortality is consistently less than 15%. So it's made a big difference to our environment. Other people have had similar experience. The difficulty with interpreting these articles, though, is that it's very, very seldom, in fact, it's never just the introduction of one factor. So it's not just the introduction of ICP, it's about organized neurocritical care. Usually ICP is a foundational aspect of it, but it's very, very difficult to isolate its effect. And then the other group, retrospective studies where those patients monitored with ICP versus non-monitored with ICP. Now, I don't find this group useful at all. I've just put one there. Artur put a couple of other studies, that JAMA surgery one, the one in Journal of Pediatric Sciences. Again, this is for me, a very, very flawed methodology, and to the extent where I hardly look at the articles, because they take a group of patients that had ICP monitors and a group of patients who didn't have ICP monitors, and then they compare them. And what makes it worse, I think the JAMA surgery one went one worse. They just looked at the national database of doing this. And the problem is you can't control for the fact of why some patients ended up with an ICP monitor and some didn't. And regardless of the confounders that you try to take into account for, that you try to control in your statistical model, the GCS, the classification of the CT scan, based on the adult classification. You can never confound for the reason why a surgeon decided to put an ICP monitor in this patient and didn't decide to put an ICP monitor in another patient. So the idea that you can just retrospectively lump them all together and separate them based on whether they had an ICP monitor or not just makes absolutely no sense. You see that kind of thinking sometimes in intraoperative neurophysiology as well. So some people have compared patients who had intraoperative neurophysiology and those who didn't have intraoperative neurophysiology for a whole range of conditions and think that those two groups are comparable. Of course, they're not comparable. So the patients you put in a monitor for the patients you do intraoperative neurophysiology for are always more complicated patients with a higher expected mortality. So I look at this kind of cohort of literature and I largely ignore it. And then it leads us to the Chestnut trial, and that trial did cause lots of consternation. Randy Chestnut is a good friend. I think he's got a very nuanced thinking about TBI, and I think he was quite taken aback about how the article was misinterpreted. So just very briefly, and Artur mentioned it already, there are key things about this trial. Firstly, no one's ever done an ICP versus non-ICP randomized control trial because ethically nobody could get it done, not in North America, not in Europe. The only way they could get it done was to do it in centers in Bolivia and Ecuador that had never used ICP monitoring before. And then what they did is they used a very specific stepwise protocol, some of which I don't really agree on, and then they looked at the outcome with no real experience and foundational knowledge of how one manages ICP monitoring. So what you're looking at is just the introduction of an ICP monitor and the value or lack thereof of a specific ICP management protocol. Now, the early mortality, as most people know, was different, but not the the late mortality. And for some reason, patients had quite a high late mortality, and the overall mortality was high by standards of a center that would be using neurocritical care. It's a mortality of 40%, so that's quite high. CSF drainage was used as a first line based on that stepwise protocol, not something that I would recommend. So these are just a couple of things about their protocol. Hyperventilation was used in 2/3 of patients. It's not a recommendation if you don't have any measure of whether you're causing vasoconstriction related ischemia with some other form of brain perfusion monitoring. So lots of problems with the article, but it was the first attempt at doing a randomized controlled trial. But unfortunately, very, very flawed because of the circumstances in which they were forced to do it. And then the interpretation, there have been several articles that have come out now, several consensus meetings, many of which included Randy Chestnut, to try to interpret the trial and bring out a recommendation from it. All of those recommendations are, don't change your indications for monitoring. This is not generalizable to places that have an investment in neurocritical care. And my view is consistent with all the guidelines. So there's a meta-analysis that was done not too long ago. The guidelines from the Brain Trauma Foundation for the pediatric portion of it, the European guidelines, and then very recently as part of this Seattle International Severe TBI Consensus Conference, it looked at a management algorithm, all of which was based on the idea of a patient having an ICP monitor. So that's the pediatric algorithm. This is the CB Consensus Conference. Neurosurgeons, neurointensivists, neurologists, trauma surgeons, everyone, all of them experts in managing patients with TBI. They came up with an algorithm, 2 algorithms in fact. The first one solely based on the patient who had an ICP monitor. So, so quite contrary to the idea of the Chestnut trial, and there you can see Randy Chestnut, third from the left there. Rather than his trial arguing against monitoring, there's been an argument for greater monitoring, in fact. So everyone agrees. When you have this kind of complexity going on in the brain of a child with a severe traumatic brain injury, there's just no way that you can manage that child with no idea of the complexity of those pathophysiological changes and pretend that you're doing a few things completely in the dark. You're much more likely to harm the patient. But, and this is a really important but, It comes back to something that Artur said. The kernel of truth in some of the things that he said is it's not about the monitor, and there's a huge potential to harm patients. So the monitor doesn't save the patient at all, doesn't make the patient's outcome better in any way. And there's a huge amount of potential to harm patients, from hyperventilating them, giving them hypertonic saline or mannitol, putting in a ventricular drain, giving them thiopentone, doing a decompressive craniectomy. Everything that we do to treat raised intracranial pressure has the potential not only to harm patients, but to kill them. So we have to think very, very carefully about how we use intracranial pressure monitoring. And there's no benefit, I'm fairly convinced, of just putting a monitor in and putting a protocol in place and expecting that patients are going to get better. It's exactly the same as all our surgical conditions. So there's no way that we'll tell a registrar with minimal experience to go take out a tumor in the lower brainstem. The outcome, the surgical outcome of those patients depend on the weight of all the infrastructure that we have, and very importantly, the surgeon's experience. If you take the surgeon's experience and the infrastructure out of that, the patient will be harmed. And I think the same is exactly true for intracranial pressure monitoring as well. So in summary, I believe ICP monitoring provides essential information, but it's not the monitor that treats the patient. It's the doctor by the bedside, and the doctor by the bedside needs to know what he or she is treating. And I truly believe that we are headed to neurocritical ICUs that focus on more monitoring and better thinking. And to a large extent, we've gone beyond intracranial pressure monitoring. It still is the foundation, but to interpret intracranial pressure properly and to treat it properly, taking into consideration the differences between patients, you have to have something additional to that. And that's all I have to say. I'm very happy to take any questions that you have.
Thank you, Tony. Excellent explanation. I think now we have more arguments to discuss this subject. Perfect considerations. And we may start with some questions from the audience. Professor Sergio Valenzuela, what is the real value of ICP monitoring in young children with open fontanelle or older children this compressive craniectomy, considering the atmospheric pressure effect in an open cranium? Makes sense to try to know the ICP monitoring on these cases?
Well, I never implant ICP monitoring in infants with open fontanelle. So this is my experience. I think it's not necessary because we can monitor it with the bulging fontanelle. So I know that it can help, but in our department we never do that. Yeah, and I think it's not necessary. Yeah. Perhaps Tony has another opinion about that.
So I can only go on my opinions, and I'm never at a loss for a strong opinion. I don't think that, I think there are two things. I don't think the sensitivity of our fingers in feeling the fontanelle is as good as we think they are. And I don't know if we can feel the difference between a pressure of 5 millimeters of mercury and 15 millimeters of mercury. I think we can certainly feel pressure of 25, 30, 40, 50 millimeters of mercury, sure. But I don't know that we can feel the difference between 5 and 15. You got to remember that neonates, by definition, have very low normal intracranial pressure. Yes. And they have very low cerebral perfusion pressure. Yes. They've got a low blood pressure. So for a neonate, a pressure of 12 or 14 millimeters of mercury may reduce their perfusion pressure already if they've got, you know, they've got brain swelling, they've got some mass effect. So I'm a little bit anxious about the idea that we can manage them only with feeling the fontanelle. I think the specificity of that technique is probably quite good, i.e. if you think that the pressure is elevated because the fontanelle is bulging, the pressure will be elevated. I don't think the sensitivity is good to tell the difference between smaller level, at least lower levels of intracranial pressure. And you've got to remember that for neonate, we're not treating at pressures of 20 or 25, we're treating at pressures much lower. So it would be quite interesting though, and I think that's quite a useful study. The next time we have a series of neonates, to have somebody blinded to the ICP monitor, feeling the fontanelle and seeing if their tactile sense of the intracranial pressure is good enough to guide clinical care.
Yeah.
Thank you. Just an example, Tony, if you are operating intracranial hematoma in a small baby below 1 year of age, anisocoric at the beginning, for me, it makes sense before leaving the operating room, if it's available, to leave in place ICP monitoring. Did you agree with this strategy, or did you believe that not make sense, is too small to deal with?
I think it depends on what the circumstances are. You know, if it's an epidural hematoma, then sure, you don't expect a huge amount of brain swelling. If there's lots of contusions and there's a lot of kind of brain swelling outside of the hematoma that you're taking out, if it's a subdural hematoma but there's lots of brain swelling, if there's a focal contusion that you're taking out but there's a lot of brain swelling as well, I think that would make me more likely to put a monitor in, and also what the brain looks like by the time you've taken out the monitor, at least taken out the intracerebral hematoma. So I think there's a little bit of wiggle room for making judgment decisions by the surgeon based on what the scan looks like and based on what the brain looks like when you finish.
Okay, thank you.
And another very important thing is that the neonate, the infants in general, don't tolerate a high ICP. Normally, a high ICP in this age group is with bad prognosis. It's really very bad prognosis. Yeah.
The next question probably is for you, Artur. Sizwe and Billy. In the paper present where ICP did not affect mortality incidence in the compressive craniectomy of functional outcome, was ICP monitoring alone or in conjunction with brain tissue oxygenation?
I think is, yeah, this is I think that is the big problem, yeah. TBI is a very complex situation, and we need a multimodal monitoring. So ICP monitoring alone help not so much. So the brain tissue O2 monitoring is very important. Everything is important in this patient. So the young people sometimes think that the ICP monitoring is a treatment. It's not the treatment. It's only a tool to monitor it. So give information about the patient.
Yeah, so it's a good time to remember the late Jim Goodrich. He had lots of great sayings that we all appreciated, but one of his sayings that he came up with time and time again, I'm sure he didn't coin it himself, but he loved it, was that a fool with a tool is still a fool. And you can apply that to everywhere in neurosurgery.
Another very important comment that in this presentation, in many discussions that we have about ICP monitoring, many people wait for a receipt, wait for algorithm, yeah. And what we see, even in the international literature, is a fight between evidence, consensus, and individual experience. And we hope that in the future we find out a a way in the middle of all of this information that we can conclude a really efficient guide in pediatric TBI management.
Thank you. The next question is from Professor Salomon to Tony. Regarding non-invasive monitoring of ICP, still controversial issue. What is the practice already validates? Optic nerve, ultrasound, MRI, maybe others are already validate for pediatric patients?
Yeah, so great. That's a great question, because non-invasive monitoring is the holy grail, right? So everybody wants a non-invasive monitor, and over the years we've evaluated several different ones. The most common ones of late have been optic nerve sheath diameter, calculating that with intraorbital ultrasound on MRI, using transcranial Doppler as well. So I think those techniques have a great role to play, but like everything, we have to be mature in how we evaluate things. There's something new on the scene, and there's a massive adoption, and we think it can do everything. And then with time, we realize it's not the answer to everything, but it's got a very specific role to play. So when you look at non-invasive techniques, they almost always, one sees this pattern that there's a correlation with intracranial pressure. So if you average everything and you take a whole and kind of number of studies, there's always a correlation with intracranial pressure. But when you look at the receiving operating curves, the sensitivity and specificity for a specific ICP number isn't very good, especially in the acute setting, where the optic nerve sheath doesn't dilate as quickly as you would see with chronic hydrocephalus. And that there are, of course, differences between patients. So I think it's a great tool for following up patients with chronic or subacute pressure, where the patient can be his or her own control, following up after third ventriculostomy patients with hydrocephalus. So that's the one limitation, that there's a correlation, but the sensitivity and specificity for a specific number isn't very, very good. So the R value isn't very, very high. And then the second thing that I showed in the slide is that if it does have a role and the techniques improve, that's great, because it may play a role then in screening patients. For those patients are at greater risk of raised ICP, these patients are not at great risk ICP, and maybe we can defer the decision to put an ICP monitor. The only problem with that is that in traumatic brain injury, and it may be different in hydrocephalus, traumatic brain injury, intracranial pressure is highly, highly dynamic. So I can do a non-invasive test now, and maybe even if it was accurate, it would tell me that the pressure is not elevated, but it's not going to tell me what the pressure is in 15 minutes time. And so for any monitor that's we're going to use to guide clinical care, you have to have a continuous monitor. And preferably not just every hour, just a continuous minute to minute monitoring. So at the moment, non-invasive monitoring doesn't offer that. You can try to do continuous TCD, but it's very, very difficult to maintain that subtemporal window. And then, as I said, the correlation with absolute intracranial pressure values isn't very high.
Mm-hmm.
Thank you very much. There is other two questions in the same way. Uzi Akimi. Dr. Figaji, you argue about multimodality monitoring. The purpose is to control the diffuse brain injury and improve cerebral blood flow. But what means to you the cerebral blood flow tell you about the vitality of the neurons? Is a correlation, did you believe that there is?
So it's a complicated question, if I understand it correctly. Because cerebral, the whole idea of there are two reasons why we treat intracranial pressure, right? One is to prevent herniation, And presumably those are at quite higher levels than 20 millimeters of mercury. We don't exactly know at what pressure people herniate, and probably varies depending on the pathology and some anatomical considerations around the tentorial hiatus. But that's the one reason we treat it. And the other reason is to treat ischemia. So ischemia is quite tricky because it's tricky to diagnose as well. And it's not completely just dependent on cerebral blood flow. So cerebral blood flow is a good proxy measure of ischemia. It's better than intracranial pressure. But it's not an absolute measure of ischemia or adequate blood flow, because you need to know what the metabolic demand is. So for one patient, cerebral blood flow may be oligemic but adequate if metabolism is depressed, but may be inadequate if the metabolic need is a lot higher. So when we do multimodality monitoring, we use brain oxygenation monitoring, which is a proxy measure of a few things. It's not just perfusion, it's also oxygen extraction. So for instance, you could have a brain catheter, at least you can have a Lycox catheter in an area of brain that's infarcted and that's being reperfused, and the cells aren't functional, so they don't extract the oxygen, so you can paradoxically have very, very high levels of brain oxygenation. We've got lots of experience also with using a cerebral blood flow catheter called Hemidex. Some other people have experience with cerebral blood flow imaging. The same is true for all of them, that you have to match blood flow with metabolic need, because there's coupling, functional coupling usually in an uninjured brain, and sometimes it's uncoupled in injured brains. So we also use brain microdialysis, so that gives us a little bit more of the puzzle. So in general, if you have a high lactate pyruvate ratio and is coupled with low brain oxygenation or a measure of low cerebral blood flow, then that's probably ischemia. That's a high lactate pyruvate ratio, which reflects anaerobic metabolism, presumably because you're not getting enough substrate in. But you could also have a high lactate pyruvate ratio with a normal brain oxygenation or normal cerebral blood flow because the mitochondria are injured. And so that's a function of the primary injury, and you can't do anything about mitochondrial dysfunction. And so the oxygen, the cells, the neurons aren't able to extract oxygen. So that's why you may have a normal or very high level of brain oxygenation. But you can't do anything about that. The only thing that we can do something about are patients who are ischemic, and they're either ischemic because they've got raised intracranial pressure, or because they have poor cerebral perfusion pressure, or there's a local effect that we're missing. So that's why we use a brain oxygenation catheter, which is a good proxy of cerebral blood flow, and where possible, we also use microdialysis. So none of them gives us the whole picture. The idea, and this is the complexity of traumatic brain injury or brain pathophysiology in general, is that you put all these things together to find out what's going on in a specific patient. Don't know if that answers the question.
Probably yes. On this same question, there is some words about the value of continued electroencephalographic monitoring and transcranial Doppler. Is there necessary, useful, give good data to take the right decision in children specifically?
I presume it's for me.
Both.
Yeah. Artur, you can go ahead.
Okay. Transcranial Doppler, as Tony already said, is really difficult to do in a continuous form. Yeah, and I don't think that the transcranial Doppler is ideal for ICP monitoring. Yeah, and electroencephalogram we use in our experience in the private and the public hospital. Unfortunately, we use only by diagnosis of brain death. So routine, we don't use electroencephalogram. I don't have experience with that.
continue for both of you. Did you have some guidelines to indicate craniectomy in children? And after, what kind of craniectomy, decompressive craniectomy, did you indicate most? Is bifrontal or hemispheric unilateral decompressive? We know it's a very difficult subject. We can spend 1 hour, maybe the next Clash of Titans, but just to introduce.
Oh, I think it's not the topic of
Yes, but yes,
yeah,
but
treatment.
it's related
Yes.
to ICP monitoring.
Yes, okay.
We use ICP monitoring, or it doesn't matter the ICP monitoring when you indicate the compressive craniectomy for children.
Dear Nelci, that is a very provocative question, yes? Because
we are in Clash of Titans, dear.
Yes, okay, good. First, depending the CT picture. What I do if I have a local lesion with herniation, depending the location of the lesion. We can do the frontal decompression, or we can do a parietal decompression. By diffuse lesion, I prefer to do an extensive frontal parietal decompression, both sides. It was my experience in my residence time in Germany, and I still do the same by a diffuse edema with a very high and refractory ICP. I prefer to do both sides frontal parietal decompression, open the dura and pray.
Preserve midline bone, Artur, if you understand your answer?
Yes, yes, I prefer preserve the midline.
Okay, thank you.
So,
Tony, did you use ICP monitoring to indicate the compressive craniectomy or not?
No, of course, in the same time, craniectomy, the compressive, and ICP monitoring.
Okay.
So just briefly, and as you intimated, we could, we'd be here for a lot longer than an hour talking about decompressive craniectomy. There's nothing that has split up professional relationships and even marriages like decompressive craniectomy. But just very, very briefly, if I could sum up my take on it, I believe decompressive craniectomy is a really, really valuable tool. But only in the right hands and in the right circumstances, because there's a considerable potential to get it wrong. And over the years, even though I'm a big fan of decompressive craniectomy, over the years I've done it less frequently as I've been better at medically managing patients. So the number of patients that end up with a decompressive craniectomy now compared to where I was 10 years ago, probably a lot less. Not because I'm less a fan of decompressive craniectomy, just because I think my medical management, particularly with multimodality monitoring, has become a little bit more finessed. In terms of the actual procedure, I've never done it by bilateral hemicraniectomies. I've done hemicraniectomies as well as bifrontal. I try to make decisions based on the individual patient's merit. If there's unilateral swelling, if there's midline shift, then I tend to do a hemicraniectomy. A key thing about the craniectomy is to get all the way down to the temporal base, because one wants to decompress at the tentorial hiatus, because you're trying to prevent herniation. If one is going to do a bifrontal for diffuse injury, no midline shift, then one has to do it properly. And I've seen more bifrontals badly done than I think hemicraniectomy. So if somebody doesn't have a huge amount of experience, I'd suggest a hemicraniectomy. For a bifrontal to work, you've got to take it quite far back, and you still got to get the temporal bone out, and then preferably you've got to close off the superior sagittal sinus at its anterior base, tie it off, and then lift the whole dura so you can put a dural patch over here. So I think technically it takes a little bit more work. Certainly very doable, but you need to know what you're doing.
Excellent. Thank you very much. Very difficult questions, but maybe the next clash of titans, we can think about this very difficult subject. Maybe you can split some marriage like you tell us. I think most of the questions are already answered. There is from Nikita, maybe. Congratulations for both excellent lectures, excellent. I think the correlation with optic seat nerve diameter we already spoken. Did you have something to add? We already talked about the non-invasive and non-continuous monitoring is useful, but we need continuous evaluation to be sure that we are on the right moment, on the right place, on the bedside.
Yeah, but it may be a very good way of screening patients who, as Artur said, the indications for who you put in ICP monitoring aren't very clear. So it may be an excellent screening tool that may add to a visual impression of the CT scan, trying to decide which patients have raised pressure. So using transcranial Doppler, using optic nerve sheath diameter may give us just a little bit of extra benefit as an additional tool.
One question to you, it's my question, Tony. You talk about intact autoregulation and impaired autoregulation. What signs you have to know if autoregulation is already gone and you don't have any more the answer you'd like to have for your treatment? I know it's multi-parametric answer, but did you have some of them most linked to loose autoregulation and you need to go faster on change your parameter quick to try to save the life?
Yeah, so at the risk of making it a little bit too complex for some people to the point where they start rolling their eyes, autoregulation is tricky. Because it's not necessarily dichotomous that one patient has intact autoregulation, one patient has impaired autoregulation. What often we see is that there's a gradation of the strength of autoregulation. So some patients, for example, may autoregulate within a narrow blood pressure window. And so their upper level of inflection and the lower level of inflection, the point at which cerebral blood flow changes passively in response to blood pressure, those may both be narrowed. So, or it may be completely gone and they've got absolutely no autoregulation at all. So that's the easy one, really. The easy one to spot, maybe the more difficult one to treat. But just very briefly, for those of our listeners who aren't familiar with autoregulation is simply the active capacity of the vascular bed at an arteriolar level to contract or dilate in response to changes in blood pressure. So normal autoregulation, your blood pressure goes up and your blood vessels contract. So you get lower pressure but lower flow because the diameter, at least higher flow, but a higher speed because the diameter is narrower, but there's a higher pressure, so the cerebral blood flow is preserved. And vice versa, when you lower your blood pressure, you vasodilate. So you've got a lower pressure, but a larger vascular diameter. So that also preserves the blood flow. It never quite looks like it does in the physiology textbooks. In the physiology textbooks, you see that lovely curve of it goes up to 50 and then it plateaus and then it goes up again after 150 in adults. So it's not exactly like that. But broadly speaking, cerebral blood flow is more or less controlled by this change in vascular diameter. And when you have no autoregulation, then that means your cerebral blood flow is completely and passively dependent upon changes in blood pressure. So at the lower end, that puts patients at the danger of ischemia, so they don't have the buffer that we have to maintain cerebral blood flow. Or at the slightly higher end, you put them at risk of hyperemia. So you're increasing cerebral blood volume in the brain because the vascular diameter is increasing, and therefore you're pushing up intracranial pressure. So it's important to spot the patients with impaired autoregulation, because those are the patients you're going to harm by trying to chase some mythical cerebral perfusion pressure. So I've just seen that situation so many times that, that the doctor by the bedside is trying to chase a cerebral perfusion pressure of 50 or 55 millimeters of mercury or 60 millimeters of mercury, and just pushing in fluids and pushing in inotropes and then pushing the blood pressure. But as the blood pressure goes up, because there's no autoregulation, the intracranial pressure goes up in parallel. And so you never get to your perfusion pressure, and then the patient herniates. So that's not a good outcome. It's good to be able to monitor for impaired autoregulation. Not everybody is set up to do so. This is one of the good roles of transcranial Doppler, so you can monitor flow velocity while you increase blood pressure, and then you can work out vascular resistance. But not many people are set up for that. There's a good passive way to do it. It's a rough and ready way to do it, but it's generally quite good, where you look at the correlation, a continuous correlation between blood pressure and intracranial pressure. So we use a software program developed at Cambridge University called ICP Plus. It's a great program. I don't have any shares in it or anything like that. It's a great program to continuously plot your data points, as well as work out correlations between blood pressure and intracranial pressure, for instance. But not everybody's got that, and that's quite expensive. So what I find is the most useful thing, if you're worried about impaired autoregulation, is to be by the bedside and to raise the blood pressure. Most of these patients are on some form of inotrope. To gently raise the blood pressure about 15 to 20% of its baseline over a couple of minutes, and see what happens to the intracranial pressure. If the intracranial pressure goes up, then the chances are the patient has impaired autoregulation. And you shouldn't, in those patients, you really shouldn't be pushing the blood pressure. If the intracranial pressure stays static or slightly drops, those patients likely have intact autoregulation, and you've got a much greater buffer capacity there for changes in blood pressure.
Excellent, Tony. Great. For me is almost perfect. Some of you would like to do some question to each other before we call Sandeep for the next session, introduction and comments. You are mute, Tony.
I was just saying, hey, Sandeep,
Okay.
how you doing?
Yes. Congratulations, Tony. The ISPN. Sandeep is here in the picture. Hello, Sandeep.
Hi.
Yeah, you are later.
No.
No?
I've been a silent spectator from the background.
It's okay. Okay. Thank you very much. It was really a very nice opportunity to talk about so exciting topic. Yeah. Thank you for the opportunity.
Well, thank you, Tony, and thank you, Artur, for a wonderful evening. I have to tell you that this session has recorded the largest number of questions in the Clash of the Titans so far. And you've certainly crossed 90 minutes in the debate. And Nelci's managed to telescope some of the questions into one, otherwise we'd still be here for another good half an hour. But thank you very much, and thank you, Nelci, for kindly chairing the program. So it now just remains for me to answer one question that has not been answered by the speakers, because it wasn't directed at the speakers. And we've had two people ask the question, do we get certificates for registering and listening to this Clash of the Titans? And the answer is that the Education Committee has pondered about it and thought, yes, if you want, we will arrange for e-certificates to be given. But rather than give one for every Clash of the Titans event, and as you know, this is Clash of the Titans number 5, and we're likely to go through about 12 or 14 before the end of the year. So it would make sense at the end of the year, maybe around December, that you can write to us and tell us which ones you've attended. And of course, the records are available with the ISPN office. And then you can get a sort of a combined certificate saying you've attended the Clash of the Titans on this date, and therefore so many hours. I think that would make sense rather than give one certificate for every Clash of the Titans. So now as we end, it is just my pleasant duty to thank everybody and to remind you that we will be back with episode 6 of Clash of the Titans. And that's going to be on the 21st of August, 1 p.m. GMT, as always. This time, there is a unique feature about this Clash of the Titans. We really have 2 major Titans involved. It's the first time we have 2 ex-presidents of the ISPN pitted against each other as we debate on a not necessarily completely pediatric neurosurgical, but a much, much more global and wider topic. And the topic for the debate on the 21st reads, post-pandemic, the idea of global neurosurgery is irrelevant. Speaking for the motion, past president of the ISPN, Professor Graham Figan from South Africa. Speaking passionately against the motion, a man who, in fact,
probably we have some connections, communication. Sandeep, you still there? You still here? Hi, Sandeep. Probably is the emotion for the next Clash of Titans.
Yes.
Yes, we hope everyone will join us August 21 with Graham Figan from South Africa, William Artness from UK, and the global pandemic, the idea of global neurosurgery is really irrelevant. You still with us, Sandy, please? Let us know if you are on board. Probably we have some connections problems. If you don't have anything to add, I'm glad to be with you. Thanks, Tony. Excellent discussion. Thanks, Artur. It was fantastic. And namaste for everyone. We can hug each other, but few hugs. And thanks for the audience. It was excellent. Thanks for the question. Your participation was very important for the discussion and increase our knowledge about ICP monitoring in children. It was fantastic discussion. Thanks for everyone.
Thank you, Nelci. Good to see you.
And I hope to see you very soon. Ciao.